In this lecture, we'll be talking about some of the risk factors for musculoskeletal injuries. We'll also discuss some of the more common musculoskeletal injuries in the workplace. The most common workplace injuries actually involve slips, trips, and falls, and we'll talk about how to avoid those in a future lecture. But for now, we're going to focus on the second most common injuries, which are repetitive strain and overexertion injuries. One of the most common repetitive strain injuries is carpal tunnel syndrome, and another really common one is going to be cubital tunnel syndrome. These injuries are very prevalent in office settings and among workers performing manual labor. Before jumping in too far, let's have a very basic review of the upper limb anatomy. The wrist flexor muscle groups originate at the medial epicondyle, and the wrist extensor groups originate at the lateral epicondyle. This is important to remember when considering the risk factors for repetitive strain injuries of the elbow, forearm, wrist, and hand. The tendons of the flexor digitorum profundus, flexor digitorum superficialis, and flexor pollicis longus pass through the carpal tunnel, which is the osteofibrous canal formed by the carpal bones and the flexor retinaculum. In addition to the tendons of the flexor muscles, the median nerve also passes through the carpal tunnel. The median nerve and flexor muscles are subject to stresses whenever we're resting our wrists on a surface or contracting the flexor muscles with high force or high repetitions. Activities that involve extreme wrist flexion or extension for prolonged periods of time also increase pressure on the carpal tunnel, as does operating vibrating tools like a palm sander, hair clippers, or a hammer drill. Since carpal tunnel syndrome is related to compression of the median nerve, it can either be due to inflammation of the synovium or from direct pressure on the median nerve, such as resting on a sharp edge of a desk or a table. When assessing carpal tunnel syndrome, the primary symptoms most people will experience are neurological symptoms in the distal thumb, index finger, middle finger, and the posterior aspect of the distal ring finger. These symptoms present as paresthesia, which is numbness and tingling in the median distribution, as well as pain and weakness in the fingers. The symptoms tend to get worse at night as inflammation applies pressure on the nerve throughout the day. When we're looking to minimize the risk of carpal tunnel, it's important to minimize work outside of safe ranges. In this diagram, we can see the safe operating range in green, which is about 10 degrees of extension or flexion and 5 degrees of radial or ulnar deviation, and the OK range in yellow, which is about 25 degrees of extension or flexion and 12 degrees of radial deviation or 16 degrees of ulnar deviation. Now, this is a fairly limited range of motion, so many tasks may require or encourage positions outside of this comfortable range. Let's look at a practical example of this. Most people should be experienced with typing on a keyboard. It's quite common to see excessive ulnar and radial deviation when typing, and the design of most keyboards with feet that raise the back up encourages excessive wrist extension. To make typing more comfortable, we should consider providing a soft supportive surface to rest the wrists on while having the keyboard flat or at a slight decline and maintaining neutral wrist deviation. If you're trying to help somebody rehabilitate from carpal tunnel, there are many exercises you can do. Most of them are focused on stretching and strengthening the muscles of the forearm and hand. Contrary to historical treatments for carpal tunnel that involve invasive surgery to relieve stress on the flexor retinaculum, the current preferred treatment approach is to minimize activities that could exacerbate the condition, immobilize the wrist with a splint, and perform regular stretching and strengthening exercises with the supervision of a physiotherapist. This is often done in conjunction with anti-inflammatory medication. If non-invasive treatment is unsuccessful, then surgery to sever the flexor retinaculum may be considered. Another common upper limb repetitive strain disorder is cubital tunnel syndrome. While carpal tunnel is impingement of the median nerve, cubital tunnel is impingement of the ulnar nerve. This is the nerve responsible for that funny feeling you get when you bonk your elbow. The ulnar nerve feeds the ulnar distribution of the hand, which includes the ring and little finger. This musculoskeletal injury is caused again by pressure, either direct pressure from resting your elbow on a hard surface or due to inflammation at the elbow. Cubital tunnel syndrome leads to weakness of the intrinsic muscles of the hand and the flexors of the ring and little fingers and causes tingling and pain in your ring and pinky fingers. It also causes pain and aching in your elbow. It can lead to greatly decreased grip strength and problems performing a pinch grip between the thumb and index fingers. The major occupational risk factors for cubital tunnel are resting your elbows on a hard surface, such as a desk or the arm of a chair, and with repeated bending and straightening of the arm, particularly while in awkward postures. High force and high vibration, such as swinging a hammer, can also lead to the development or exacerbation of this condition. The primary treatment for cubital tunnel syndrome is rest, nerve gliding exercises, and anti-inflammatory medication. In rare cases, surgery may also be indicated. Next, let's talk about thoracic outlet syndrome, which is a complex disorder resulting from compression occurring in the space between the clavicle and the first rib, which is adjacent to the superior thoracic aperture. Narrowing of this passageway causes compression of the subclavian vein and arteries, as well as the brachial plexus, which is a bundle of nerves that passes through this space. As an individual elevates their arm, the space between the clavicle and the first rib narrows, increasing the likelihood of compression. This also happens with poor neck and shoulder posture, such as excessive forward head position, protracted shoulders, or dropped shoulder. And to be clear, we're referring to the condition dropped shoulder, which affects the scapula. We're not actually talking about depressing the shoulders, which can increase space between the clavicle and the first rib. Now, this compression manifests in two distinct forms of thoracic outlet syndrome due to the varied structures involved. The symptoms can either be neurogenic or vascular in nature and are attributed to the compression of the brachial plexus nerves or the subclavian veins and arteries, respectively. Neurogenic symptoms often present as numbness and tingling in the fingers, coupled with pain in the shoulder and neck region. An aching sensation may radiate from the shoulder down to the hand, and in extreme cases may even result in weakened grip due to insufficient innervation. On the other hand, vascular symptoms are characterized by noticeable discoloration, typically bluish in hue, in the hands or sometimes extending up the arms. This is due to subclavian vein thrombosis, essentially blood clots, which can lead to swelling and pain. In some instances, a throbbing lump near the collarbone might appear. This is indicative of inflammation or thrombosis. A less common but more serious symptom involves infarcts in the fingers, which are small black dots signifying tissue death due to lack of blood supply. The major occupational risk factors that contribute to thoracic outlet syndrome include repetitive, forceful overhead lifting and prolonged poor seating posture, particularly with the shoulders rolled forward while typing on a keyboard. That's probably what most of you are familiar with. These actions exacerbate the compression in this area between the first rib and the clavicle and can lead to significant pressure on the structures passing through it. Preventive measures largely revolve around maintaining good posture, so sitting with your back upright and shoulders retracted and depressed. And treatment parallels the approach for carpal tunnel syndrome, combining stretching and strengthening exercises. The objective is to strengthen the muscles, particularly the muscles of the chest, to better withstand loads, and elongate the muscles, which creates additional space between the clavicle and the first rib, which alleviates the compression. For severe vascular thoracic outlet syndrome, blood thinners can be used to treat the clots. Examples of occupational environments predisposed to thoracic outlet syndrome include jobs that demand extensive computer use, assembly line work, or positions requiring repeated overhead lifting, particularly forceful overhead lifting. Being aware and adopting ergonomic practices in such settings is fundamental to mitigating the risk of thoracic outlet syndrome and promoting a healthier workplace. Raynaud syndrome is a condition characterized by a notable reaction to cold or stress, and it impacts blood circulation in the fingers and toes. The syndrome can manifest as a primary disorder, which is often hereditary, or as a secondary disorder, referred to as acquired Raynaud's, which can either be associated with certain occupational activities or other medical conditions, particularly autoimmune diseases. While there's a correlation between specific jobs and an increased incidence of Raynaud syndrome, causation has not been definitively established. However, the symptoms and their mechanisms are fairly well understood. The hallmark symptoms include fingers turning white and then changing to a blue hue when presented with cold, and this is due to diminished blood flow. And this occurs because of the loss of nerve control over the blood vessels, which leads to their constriction in cold conditions. The constricted blood vessels can then spasm so that they're contracting and then having a rapid dilation, and it's essentially cutting off the blood supply and causing color loss in the affected extremities. This process can result in numbness, tingling, and at times extreme pain. It's important to remember that under normal circumstances, the artery should remain sufficiently open to allow blood flow to the extremities, ensuring an adequate blood supply. While our body has a natural mechanism to constrict blood flow to the extremities to preserve core temperature in extremely cold environments, individuals with Raynaud's experience an overreaction even in milder cold conditions. The consequent cycle of constriction and dilation causes the extremities to change colors from white to blue during prolonged cold, and then red when warmed up. This process is usually associated with significant pain. Occupational risk factors for Raynaud's disease include the use of vibrating tools. For instance, prolonged exposure to high-frequency vibrations from equipment like jackhammers and rotary hammer drills without proper protective gear can potentially damage nerves in the hands that regulate blood vessels, leading to acquired Raynaud syndrome. Occupations involving repeated shocks, vibrations, and forceful hand contact, such as swinging a hammer, also increase risk factors. Understanding these risk factors and providing appropriate ergonomic interventions and protective measures, such as vibration dampening gloves and regular breaks from the use of vibrating tools, can significantly mitigate the risks associated with acquired Raynaud syndrome in the workplace. Rotator cuff syndrome is a common musculoskeletal disorder, especially among athletes and occupations with repetitive upper body activities. It pertains to the damage caused to the tendons or muscles of the rotator cuff, resulting in swelling, pain, and often functional impairment of the shoulder joint. Before delving into the intricacies of the syndrome, it's important to understand the anatomical components involved. The rotator cuff is comprised of 4 muscles: the subscapularis, supraspinatus, infraspinatus, and teres minor. These muscles play a crucial role in stabilizing the shoulder joint and enabling a wide range of motion, particularly facilitating rotation, but also involved in abduction. However, due to their relatively small size and the high demands placed on them during forceful or repetitive movements, they're particularly prone to injury. Key signs of rotator cuff syndrome include pain and/or weakness during the flexion, extension, abduction, or rotation of the arm, particularly against resistance, as well as pain radiating along the outer shoulder, down the arm, or occasionally up to the neck. The discomfort often is exacerbated at night due to prolonged inflammation and may be accompanied by stiffness in the shoulder joint. Examining the shoulder, particularly where the tendons of the rotator cuff muscles attach to the humerus, can reveal tender spots, indicating possible tendon irritation or disruption. This is often the primary distinguishing characteristic of rotator cuff syndrome. Prevention and management primarily hinge on strengthening the rotator cuff muscles. Light-resisted exercises are preferred for rehabilitation rather than heavy weight training, as higher forces primarily target the larger muscles of the shoulder. Utilizing exercise bands for external and internal rotations, and performing static pushes against the door frame, or working on flexion and extension exercises with light resistance are very effective strategies. Additionally, incorporating flexibility training can further mitigate the risk and alleviate symptoms of rotator cuff syndrome. Now we're going to discuss tendinopathies, which include disorders like tendinitis, tendinosis, and tenosynovitis that adversely affect the tendons. Broadly characterized, tendinopathies fall into 2 groups: tendinitis and tendinosis. Tendinitis is acute inflammation of the tendons, typically caused by traumatic events leading to strain and tearing of tendon fibers. This condition represents the initial stage of tendon injury. On the other hand, tendinosis reflects a chronic manifestation where recurring minor tears and partial healing happen over time, exacerbating the damage. This is what we label as a cumulative trauma disorder, often witnessed in the wrist, elbow, and shoulder due to repetitive forceful activities. Taking a specific look at lateral epicondylitis, commonly referred to as tennis elbow, and medial epicondylitis, which we term golfer's elbow, these conditions are typical examples of a tendinopathy. They result from overuse or deterioration of tendon fibers, either through extensive wrist extension or flexion. Point tenderness, possibly accompanied by visible or palpable swelling, is a telltale sign. Pain radiation down the back surface of the forearm signifies lateral epicondylitis, while pain along the anterior surface of the forearm indicates medial epicondylitis. Typically, these tendinopathies are due to forceful utilization of the respective tendons, commonly seen in activities like hammering, forceful grasping, typing, and many sports. The primary site of injury to the tendon in these conditions will be at or near the insertion point onto the humerus at the origin of the muscle. This is where the majority of discomfort is felt and where there's likely to be significant swelling. Treatment protocols revolve around a combination of strengthening and stretching exercises targeting the affected tendon and muscle groups. For lateral epicondylitis, focusing on strengthening wrist extensor muscles is key, while medial epicondylitis necessitates working on wrist flexor muscles. For preventive measures, braces, particularly compression bands that are worn just below the elbow, are a common treatment measure. While they may offer temporary relief, the medical consensus suggests that these don't provide long-term benefits. The optimal treatment strategy is to avoid activities that increase irritation to provide sufficient time for the structures to heal. Tenosynovitis is inflammation of the synovial sheath surrounding the tendon. It's important to distinguish this from tendinitis, as this is inflammation of the tendon, while tenosynovitis is inflammation of the synovial sheath. Tenosynovitis can be extremely painful, and it can lead to pronounced swelling and strength loss, and may even lead to loss of function in the affected limb. Let's discuss a couple of specific disorders involving tenosynovitis. First, we have stenosing tenosynovitis, which is commonly referred to as trigger finger. This is a condition where the tendon's smooth gliding through the tendon sheath is compromised, leading to the tendon catching in the sheath. The primary cause of this condition is the formation of a nodule on the flexor tendons of the fingers and thumb. This nodule catches while gliding through the tendon sheath, causing difficulty or even an inability to straighten the thumb or the fingers post-flexion. It's also associated with pain, discomfort, and swelling. However, it's possible for this disorder to manifest without pain. Trigger finger exhibits a higher prevalence in females compared to males and is typically observed in individuals between the ages of 40 to 60 years old. Although largely appearing in this age demographic, it can also be a congenital disorder where individuals are born with a tendon nodule, setting the stage for Tenosynovitis from an early age. Examining the work-related stresses, the use of tools with hard handles is a primary contributor to this condition. Tools such as pliers or even broom handles and shovels, when used extensively, pose a risk. The hard, unpadded handles irritate the tendons, eventually leading to nodule formation. This nodule then disrupts the tendons gliding through the sheath, and upon flexion, the nodule is dragged through but gets lodged, preventing the straightening of the finger without assistance. Treatment centers around finger strengthening exercises, stretches, and tendon gliding exercises. Tendon glides involve curling the fingers and then stretching them out, promoting smoother tendon movement over time, though it's important to not overdo it as it could lead to increased inflammation. De Quervain's disorder is another example of Tenosynovitis. This is typically caused by repetitive actions like the back and forth movement on washboards or thumb tapping on modern devices like smartphones. This disorder has even been colloquially termed texting thumb or BlackBerry thumb, though from my experience maybe it should be called Nintendo thumb. De Quervain's is typically characterized by pain and swelling near the base of the thumb, and difficulty moving the thumb and wrist during grasping or pinching actions. It can also lead to a sticking sensation in the tendons of the thumb, similar to stenosing tenosynovitis, but usually to a lesser degree. Unlike some other tendinopathies, de Quervain's is usually easily palpable and presents with visible swelling both in the tendon and its sheath, particularly affecting the tendons of extensor pollicis brevis and extensor pollicis longus. While some cases of de Quervain's require surgical intervention, it's usually treatable in a similar fashion to most tendinopathies by providing rest and reducing inflammation with non-steroidal anti-inflammatories. Another upper limb repetitive strain disorder that can occur is the formation of ganglion cysts. These result due to the accumulation of fluid within the tendon sheath, bearing some resemblance to de Quervain's but distinguished by its location. These cysts predominantly occur around the wrist, specifically near the radiocarpal and ulnocarpal joints. Although there can be many different causes, impact, repetitive strain, or genetic predispositions are common factors. Ganglion cysts often present as benign, non-painful lumps requiring no intervention, though common treatments include splinting or aspiration where the fluid is sucked out of the cyst. When pain is present, surgical removal is typically preferred as it prevents recurrence. Now let's move on to discussing some lower body musculoskeletal disorders. Most of us have probably experienced a lower body musculoskeletal injury at some point in our lives. A common example would be back pain experienced due to prolonged sitting. Now this is very common for both students and educators. Muscle strains and sprains arise due to damage to the muscles, tendons, and ligaments and are caused by acute trauma, often when lifting or carrying heavy objects. This damage leads to significant back pain but typically subsides after a number of days, up to a couple of weeks. These injuries typically involve damage to the erector spinae muscles, which are the large and robust muscles responsible for spinal extension that run from the pelvis to the neck. The erector spinae muscles bear the primary load during lifting, especially when executed properly, and are involved in flexion and extension movements. The quadratus lumborum also assists with this, as well as stabilizing the back during rotation. Many muscles are involved with stabilization of the spine during lifting and postural control. For instance, it's crucial to ensure the activation of the transverse abdominis muscle for stabilization. The transverse abdominis, which is often referred to as the corset muscle, also provides stabilization to the structures in the lower back. Its automatic contraction anticipates body movements, safeguarding the spinal joints, ligaments, and discs, as well as the nerves by restricting excessive movements. While the transverse abdominis can provide a tremendous amount of core stability, it's not a commonly injured muscle. The stabilizing muscles most prone to injury include the multifidus and the muscles of the pelvic floor. When subjected to twisting and side bending, these small muscles undergo significant strain and are likely to be sprained or strained. In a scenario where one bends over to pick something up and feels a tweak in your back, it's likely a damage to the multifidus muscle rather than the erector spinae. The multifidus muscle primarily aids in stabilization during twisting movements, and with its limited range of motion, it's really designed for minor corrections and functions as a primary postural control muscle. On the other hand, the pelvic floor muscles work in conjunction with the transverse abdominis to stabilize the lumbar spine, and underutilization of either of these results in additional strain on the multifidus and the erector spinae. To prevent injuries, focusing on strengthening exercises to maintain lower back stability is vital. This includes strengthening the deep core muscles as they're essential for spinal stability. The spine is capable of a substantial range of motion, but has a very narrow range of motion that's considered safe, ideally within about 5 to 15 degrees of forward flexion and pretty much no side bending. When working, lifting with an upright back with neutral spine posture that maintains the natural lordosis of the cervical and lumbar regions and kyphosis of the thoracic region is optimal. Hyperextension during lifting and carrying escalates the strain on the back and can particularly stress the spinous processes in addition to the ligaments. While it may not be always feasible to modify job tasks to maintain the optimal safe range, striving to structure work to adhere to this range as much as possible is crucial for minimizing the risk of injury, as well as specific training for safe lifting techniques. Facet joint pain occurs where the ribs meet the spinal column, often manifesting as inflammation and irritation that leads to swelling. This condition can lead to significant pain during forward and side bending activities. Inflammation of the facet joints leads to palpable swelling that's accompanied by severe pain that may make it difficult to sit or stand upright. In some cases, it may even be difficult for the individual to breathe deeply. Facet joint syndrome is an arthritis-like condition of the spine that's caused by degeneration of the cartilage and is usually caused by poor posture and repetitive movements. Spinal disc erosion is a commonly observed condition in jobs that primarily involve sitting and is caused by prolonged compression of the spinal discs. This compression leads to reduced intervertebral space that can impinge on the nerve roots, which is incredibly painful. Since sitting puts more pressure on the spinal discs than standing, prolonged sitting is the leading cause of disc erosion, particularly when sitting with the back unsupported. And while it's primarily caused by seated activities, it can occur due to prolonged standing, especially while bearing heavy loads such as carrying a backpack. And while disc erosion is generally considered to be a degenerative process that's common with aging, prolonged sitting tends to exacerbate this condition and definitely leads to a much earlier onset. Sciatic nerve impingement, often referred to as sciatica, is a common condition associated with prolonged sitting. It presents with pain, numbness, and paresthesia in the leg on the affected side and often leads to very weak muscles in that leg as well. It's caused by compression of the sciatic nerve, usually by the piriformis muscle. Treating sciatica primarily involves stretching, particularly of the piriformis muscle, to alleviate pressure on the sciatic nerve. Unlike many other musculoskeletal conditions, strengthening exercises may not be as beneficial in this case and could potentially worsen the situation. However, strengthening exercises aimed at the posterior chain muscles, such as the glutes and hamstrings, could provide some benefit, along with regular low to moderate intensity endurance exercise. Disc herniations occur when the inner portion of the disc protrudes from the spinal column and puts pressure on the nerve roots where they exit the spine. This leads to intense pain or numbness in the affected region and is most typically observed in the lower back. Due to their relatively poor healing capacity, unlike many other musculoskeletal disorders that tend to have a better prognosis with adequate rehabilitation, this tends to lead to more severe cases where disc herniations will necessitate surgical intervention to alleviate the symptoms and prevent further complications. Interestingly, in younger individuals, they may experience spontaneous recovery from minor disc herniations, although the phenomenon is less likely as one ages. And while the cause of disc herniation may vary, poor sitting posture and improper lifting techniques have been identified as primary risk factors. Particularly, forward flexion during lifting exacerbates the risk as it opens up the space in the posterior spine, making it easier for the disc to protrude. And though posterior herniations are predominant, anterior and lateral herniations are also possible. However, they usually manifest with less intense pain since they're less likely to result in nerve impingement. Management strategies for disc herniation center on prevention and early recognition, as severe herniations often require surgical intervention to fully resolve and are associated with a very lengthy recovery process. Ergonomic interventions are one of the most effective methods for reducing the incidence of disc herniations in the workplace. We can provide appropriate training for lifting safely, and we can also minimize the situations that require lifting during awkward postures through retooling or redesign of the workspace.